Good afternoon and welcome to the webinar. Thanks so much for coming and registering for this event today. Regina and I are going to talk about health reform and budgets and how they impact the HCH community. I'm Barbara DiPietro. I'm the Senior Policy Director here at the National Council. I'm here with my colleague Regina Reed, who's our Health Policy Organizer. And today we are going to do a really fast-paced overview, a structural analysis of health and housing and the budgets. So you're going to be making a very efficient use of an hour because we're going to cover a lot of material. We're going to do it fairly quickly because there's a lot to talk about. There's a lot of implications, and in particular, and possibly most important, Regina's going to talk about how we can really be active in shaping the healthcare system that we really need to see, particularly one that best serves people experiencing homelessness. I think the Council has long established healthcare as a human right, but we also believe that a healthcare system that's designed and serves people who are homeless very well is going to serve everyone very well. So if we can make that system work for our folks, then that can be good for everybody. So with that, let's plunge in. One thing I will say, you'll see at the bottom of your screen here a question and answer box. We're going to save some time at the end of this presentation for questions and answers. So if you've got something, particularly because we're probably going to hit things very quickly, we can come back and clarify some things that you'd like for us to talk more about at the end. So don't feel shy, just put that in there. And then you will also see a box that has a file, HCH Health Reform Slides. These are the slides that are in a PDF form. Please use these slides as resources for you. We'll also have a resource sheet at the end that'll have a lot of links to more information about a lot of the topics that we'll cover today. So we want to make sure that you've got this. You don't feel like you have to scribble furiously. You have these slides that you can refer back to as well as share with others. Okay, so with that, let's just plunge in. So one of the things we want to talk about is just the big picture. So right now we just really don't know what's going to happen with health reform. There's a lot of uncertainty, and this is both at the federal and state level, since states, particularly with regard to Medicaid, have got a lot of flexibility on what those programs look like. And so we really want to pay attention not only what's happening in Congress, but also what's happening in HHS at the federal level, and then what your state's Medicaid directors and your Medicaid plan is doing. Right now in Congress, we've got a lot of conservative leadership roles, and now that we have a new administration, that view is also mirrored in the administration. So we have fewer protections against some of the kinds of changes that have been proposed in the past that have always been blocked. Now we don't have those same blocking points. And so I think that's particularly where our action and engagement is important. And then obviously we know that moving forward, how the HCH community is planning in terms of its own growth, how we're serving our patients, a lot of this is going to hinge on the housing and healthcare resources that we have at hand. So this is all important just to kind of have as a framework. When we think about where we are currently, but really just a status as of November, so going into the election, we were really looking at improving coverage and access to care. So we knew we still had 19 states that had not yet expanded Medicaid. So that was very important, and we saw a lot of folks in those states, up to 3 million people, who had lacked access to any health insurance coverage because their states didn't expand Medicaid. And that caught a lot of people experiencing homelessness remaining uninsured. But we see also from the UDS numbers and the data that health centers submit to HHS that just because you're an expansion state doesn't mean that everyone that is eligible is enrolled, and we know that everyone who's enrolled is not necessarily accessing the care that they need. But there had been tremendous inroads in making improvements there. We were starting to see a lot more data come out about health improvements and connections to care. We were starting to see payment reform and quality initiatives. We started seeing both insurers and hospital systems and state Medicaid systems look at how social determinants of health, like lack of housing and lack of food, lack of income, healthy environments, how those all played into the healthcare system we were trying to achieve at all states. Even ones that hadn't expanded Medicaid were still trying to reform their system and had taken the needs of low-income people into account, obviously partially, but still we're recognizing that. And so thinking about how housing supports and medical respite programs and all of that fit in, those were part and parcel of those plans. Where we find ourselves now, we spent March talking about the American Health Care Act, And in particular with Medicaid, there were a lot of things that were going to undermine the work that had been done to date. Particularly repealing the Medicaid expansion would obviously be a key to that. But moving to block grants and moving Medicaid to per capita caps were some of the financing changes that had been suggested. Repealing the essential health benefits in Medicaid plans, ending retroactive coverage, limiting presumptive eligibility. So it made it a lot harder to determine people eligible and get them into the program. There would have been work requirements that Congress had recommended. And then they were also looking at how they could require stronger documentation prior to enrollment. So again, getting rid of a lot of that self-attestation ability that we were able to do to get people who typically did not have documentation or IDs, getting them into the system and being able to follow up with that documentation later. Now it's really being suggested more and more that we have that documentation up front. And as homeless healthcare providers, we know how difficult that can be. You may never see your guy again. And so getting an ID ahead of the eligibility sometimes can be a real barrier. And then redetermination every 6 months was part of the American Health Care Act. And again, as we know, moving from an annual redetermination to basically doing it twice as often is twice as much work for many of our case managers and enrollment staff, but also makes it much harder to get folks enrolled and keep them enrolled so that they have access to the care they need. So let's just talk a little bit about some of the key provisions just for a moment. Again, the slides are here and we'll have some more resources at the end. When we talk about block grants and caps, a lot of this can really get boiled down to the mumbo jumbo of healthcare financing, which is sometimes some of the most boring material ever. But really the big takeaways on block grants and caps is that it ends the ability for Medicaid to be responsive to increases in cost of care, in the number of people who need Medicaid, and how that enrollment might fluctuate given a lot of different scenarios. We see during an economic recession, more people are out of work, and as wages go down, we see more people come into the program. A block grant would not respond to that. When we see public health emergencies like the Zika virus, the opioid epidemic, other things that come up, the water crisis in Flint, all of these have implications for Medicaid. And caps and block grants are not responsive to those needs for increased funding. Right now, Medicaid is funded on a proportion of funding between the states and the federal government. And so as need and enrollment go up, yes, the spending goes up, but the federal share of that also goes up. So states have a better ability to anticipate need and know how they're going to fund that. And we'll talk in a few minutes about why this is going to be a particularly big deal for states. But for us as providers, having a predictable Medicaid benefit is really helpful so that we can plan our revenue streams. Any business needs to do this. And a stable revenue stream, as we all know, is really key to not only ensuring how you're going to grow and which services you're able to offer, but this pays for staff. This pays for the building. It keeps the lights on. There's real infrastructure here, and local economies are based on the jobs that Medicaid provide. So these are the kinds of reasons why it's so fundamental that we push back against anything that block grants or caps the Medicaid program. When we talk about essential health benefits, really what we're talking about is getting away from those skinny plans that were offered on the insurance markets prior to the Affordable Care Act. There's 10 benefits that the law dictates. A number of those that are important for us, obviously, are the mental health and substance abuse behavioral health requirements for those benefits to be part of every plan. Maternity benefits, hospitalizations, emergency rooms, all the things that we know are needed by our population at higher rates generally than the general population. Just thinking about when you start taking away those benefits, typically what insurers are going to do is they're going to take out the benefits that cost them the most money. And we know that hospitalizations, certain types of prescription drugs, rehab services, mental health care can be very expensive. So think about the implications. If you have plans that don't have a mental health benefit, then it stands to reason that people with mental health needs will not choose those plans. And that's a way of keeping people out of care and out of the care, being able to afford the care that they need. So this is really where we're focused. And it also really then devolves into a political football. For every little benefit that a health health insurer wants to add or that advocacy groups want to add. You don't want to be in a position of really at every state trying to advocate and justify the need for mental health or substance abuse treatment in your Medicaid plan. That's just not efficient use of time or resources for anyone. So the 10 essential health benefits provided a consistent platform across all states, and that was really helpful. Now, of course, it didn't dictate scope or amount or duration of those services, and that still obviously varies widely state to state, but you at least had a platform for what you were building on. Taking away essential health benefits removes all of that and really just leaves it open to an anything goes kind of plan. Work requirements. So I have to say, this is one of the things that just vexes me the most is work requirements. The Obama administration was very clear that work requirements would not be approved in any plan. And in fact, a number of states had submitted Medicaid permissions to do so, and they were rejected. However, right now we have an administration that has said that they're open to this at the state level. So it doesn't need to happen in Congress. It can happen at your state level, and it can happen now. 4 states have already submitted requests to CMS to add these type of work requirements, which can look a lot of different ways. But generally, it applies to about 22 million people who are of working age that are currently in the Medicaid program. So Medicaid currently covers about 75 million people, covers more than Medicare, which is an important tidbit to share at your next dinner party. And 11 million people, so about half of the people that it would apply to could be at risk of losing their coverage. So that's what we're really talking about. But the reality is that most people who are on Medicaid already work, either full-time or part-time, or they're actively looking for work. So really what work requirements do is that they set up a lot of administrative barriers that you know that we as healthcare providers are going to be required to implement. And so this, this ends up setting up extra costs and extra administrative burden on the very community-based providers that we're trying to make it easier for people to provide services. And very clearly, work requirements are not related to health care. And this is the platform by which the Obama administration had said no to these, is that they weren't related to health care goals. I just find it a little ironic because I just fundamentally believe, and I think a lot of us would intuit, that good health facilitates the ability to have a job, and it's not the other way around. So putting work requirements on someone who's sick is counterintuitive. So we'd really like to see a good fight against these. When we look at the leadership at Health and Human Services in the administration, Tom Price, who is the new secretary, and Seema Verma, who's the new CMS administrator, they wrote a letter to states. And the link is here on the slide. I'd encourage everyone to check out the letter. It's very short, but it essentially outlines what they are inviting states to do in their Medicaid program. And again, it's very important to remember, this is outside Congress. Congress doesn't have to pass a law that allows work requirements. This is already allowed through the administration. And so in particular, this quote here illustrates their perspectives on the Medicaid expansion. And they just believe that without the working age adults without dependent children is a clear departure from the core historical mission of the program. And so this is a perspective that they bring into this. Both of them have extensive experience with conservative approaches to Medicaid. So both of them know what they're doing, and this is what we're working with right now. Specifically, when we look at that HHS letter in the second bullet here, you see that they're very specifically ask governors to ask for permission to implement work requirements, health savings accounts, premiums, out-of-pocket costs. And this is at all income levels. So this could go down to 0% of poverty, meaning our clients who have no income could be subject to premiums and out-of-pocket costs and requirements that no doubt we would understand would cause a barrier to care. The administration has really signaled, too, very little support for the current law. On inauguration day, the president had signed an executive order that basically said we are not going to support the provisions of the ACA that cause any onus on states or insurers. And so while it's a little unclear on what the implications of the order is that themselves, it definitely illustrates the philosophy that the administration brings. So the vehicles for how this can all happen are the most boring of public policy fodder ever, and this is why it's really incumbent that we be mindful. HHS regulations, state Medicaid waivers, All of those types of things there that tend to get less fanfare than big changes in Congress can happen very quietly at the state level. So that's really where we want to be focused. When we look at the budget, we only have preliminary information right now. More information on the budget, the President's budget, will come out in May. But just as an initial piece here, most of the proposed budget cuts out of HHS had come from NIH and CDC and some of those programs that have gotten a lot of attention. But we all know that the LIHEAP program is something that's really critical for helping the energy assistance for our clients. And obviously the mental health block grant is critical resources for us as well. When we talk about health centers in particular, a lot of folks want to ask, what's happening with health centers? The primary care cliff is that's really going to be a concern, and we really are relying on Congress to fix the drop-off in the funding that's going to impact about 70% of health center money. So for those who are health policy historians, you'll remember that the Affordable Care Act established 5 years of mandatory funding to build health centers and the capacity to see the newly insured. And so that provided, over time, up to $3 billion a year in mandatory extra money than we would normally get through our discretionary annual budget. Congress has, in order to continue that growth and sustain those operations, they have extended that ACA funding for an additional 2 years. Well, the 2 years are up, so we need to reauthorize that. And so you, through our advocacy points that Regina will talk about here in a minute, you'll find out more on how to track that and how to be engaged and really encourage your congressional members to make sure that they're on board with that. We obviously know how critical all of that is to maintaining the services that we provide at Healthcare for the Homeless and other homeless healthcare providers. So this is really key to community resources. So let's talk about states here for a second. A lot of the cuts, particularly proposals to block grant or do caps for Medicaid, you push a lot of the funding responsibility onto states. So essentially you're saying to states, we're only going to fund a portion, and then whatever else you do is on you. That's kind of what that means. So what this does is this actually puts governors in a very difficult position, because under the rubric of state flexibility, which, again, I have to come back to the fact that Medicaid is already a very flexible program, and this is why no Medicaid program looks like, every state's Medicaid program looks different. But using that rubric, they're saying, well, we want states of maximum flexibility, basically by giving them a lot less money to do whatever they want to do. And then how they respond to that is going to be very different in every state, because every state's got a different political dynamic. So how governors and Medicaid directors respond to that is going to depend a large part on advocacy at the state level. There's a lot of pressure to contain Medicaid funding. We absolutely understand that. We know that Medicaid is either the top or the #2 line item budget for states after K through 12 education. And so, yes, we understand that that's the case. But cutting Medicaid funding, as we know, doesn't actually reduce the needs of the population. So just taking a look at that, again, the key takeaway there is really puts the onus on the states to figure it out. And a lot of times what that means is that they have to either raise taxes or cut eligibility or services or rates to providers or all the things that we know states do when they're trying to do budget containment. So here's some of the provisions to look for, because, again, states are being asked to submit these types of requests to the administration for approval. More frequent redeterminations. A lot of things I've already mentioned, again, are now open season at the state level. Higher levels of documentation. And one piece, time limits on benefits. So much like the TANF program, the Temporary Aid to Needy Families, typically known as welfare, we know those got block granted, and those have a time limit. And we know that typically about 1 in 4 children living in poverty have any access to those benefits. That's what the dangers of block grants do. We don't have then the resources to be able to do that. So this whole list here mirrors some of the stuff I've already mentioned. We really have to be vigilant about that at the state level. So Hannah, if you can, by the way, everyone, Hannah is our trusty technician, and she will be putting up a poll here for those of you who are working with patients. If you could weigh in here, we've really heard from a lot of providers that are saying that patients are expressing concern about losing benefits, that they're seeing the television ads, they read the newspapers, they're really worried about what's going to happen with their own health care. And we'd like to be responsive to that. So people have said, what do I say to my patients who come in and say, am I going to lose coverage? The honest truth is we don't know what's going to happen. But we can say that this is a safe space, that this clinic isn't going away. We continue to provide health care services. We don't sell your information to immigration or law enforcement. There's no major changes that have happened yet to Medicaid or to any other aspect of the Affordable Care Act, actually. So major changes have not yet happened. And other talking points can be that if changes do get passed, by and large, the biggest changes will take many years, at least several years to implement. So nothing will happen right away. And then, Hannah, I just want to make sure that I'm able to see the whole poll. So let's see, I'm going to maximize this. So it looks like a number of you, and we've got a small crowd today, but a small crowd who are voting, but 2/3 of you have said that frequently you've seen patients or heard patients talking about this. So thank you for that. Just wanted to get a slice and take the pulse of the community. You can also share this number here, and Regina is going to have this number up a number more times, so you'll have another crack at this. This is the Congressional Switchboard line, and we should have our patients calling it because this is their constituents too, and their voice matters. So we'll also have a resource guide, as I mentioned before. On that guide is a sheet that you can pass out to your patients that we've developed with some of these same talking points. So at this point, let's see. Let's move on. Single payer. This would not be a council event without a single payer mention. If we want to talk about health reform, let's talk about real health reform. Recent polls from a number of sources have actually shown that 60% of Americans say that government should be responsible for ensuring health care for all people. That's really exciting, and that actually has grown in the last little bit. And with that growth, we've seen the single payer bill in Congress. We've seen more and more people signing on to that. In fact, in the last month, we've seen 13 more co-sponsors. If you would like to ask your member of Congress to sign on, that would be really great. We understand that Senator Sanders will be introducing a single-payer bill in the Senate next week or soon thereafter. And then a spotlight, we want to take a look at California because they've introduced a single-payer bill at the state level. And again, a lot of activity going on how we can make the healthcare system better. All right, that was a very quick overview on health, and I just want to hit some highlights on housing. Under the Obama administration, what we saw a lot was a real focus, very targeted focus on specific priority areas and goals around veterans and family homelessness, chronic homelessness, really making inroads to document changes and target resources to be able to really do best practices to alleviate homelessness. We saw a lot of changes around coordinated entry. We saw definitions of homelessness really get refined, for better or for worse, but at the same time, a real focus there. What we have now in the current administration, we really just don't know what to expect just yet. We know that the leadership there is more experienced in healthcare, but Secretary Carson does not have a long history with housing. And so we're working with him, and as are many people, to appreciate how housing and healthcare work together. But we're also concerned about the administration's proposal to eliminate the U.S. Interagency Council on Homelessness. So that is also a piece we'd like to see rolled back. The budget, again, we only got some initial figures from the President's first offering. Again, more details will come in May. But the initial offering showed that there was this is a significant cut to HUD. We know that HUD has already not got the resources to meet the housing needs of Americans. We know that 11 million households spend more than 50% of their income on housing. We know all of them are at risk of homelessness. And we know that when you make reductions to public housing and housing choice vouchers, you only exacerbate that problem. And so again, we've got some resources for more information on how that budget will impact housing. But again, this is a real area to look at and be active in your advocacy. That's a lot, and then I haven't even begun to touch on any one of these bullets can be its own hour-long discussion. There's a lot of other things that are happening on the agenda right now that are of concern for us and how they might impact vulnerable populations. So I just wanted to list them here because, yes, they're on our radar screen, but in the lightning round that you're having here on health and housing, just wanted to make sure that that got a mention. Okay, and then another thing that I want to mention before turning it over to my colleague Regina is that we have a conference coming up, and for those that can attend, we would love to have you. Really, this is 1,200 of your best friends in homeless healthcare coming together every year to share best practices, research, policy analysis, and advocacy, and really just be able to make sure that we as a community are doing what we can to provide high-quality, integrated access to the healthcare services that we know our population needs. In particular, just want to do a shout-out to the Pre-Conference Institute that will be focused on health reform and how we as a community chart a path forward, given that there's so much changing, so much that's uncertain, and it's very overwhelming. Much like my presentation today, all of it feels overwhelming. I don't know anyone who's not overwhelmed that's doing this work right now. So appreciate you being here today. At this point, I'm going to turn it over to Regina, who can talk with you about what's next and how we can all be active. So thank you very much for your time, and we'll come back to more questions later.
Thank you, Barbara. This is Regina Reed. I'm the policy organizer here at the Council, and jumping off Barbara's quick and dirty rundown of what's going on, I am going to jump into what's next. Here you see up on the screen what the Council is focusing on in our advocacy work and some action items that you can be involved in. So here is a timeline up for what's next, and it's important to remember that these are the known deadlines we have in Congress. This isn't a comprehensive list of everything that's going to happen or of all the important things we're going to be watching that's happening. This is an outline of deadlines we know that are coming up that are going to frame the busyness and the timeline of Congress. In March, Trump released some of his budget recommendations. These are just a recommendation. We know that these are considered in somewhat as dead on arrival. They're still worrisome because they set a precedent. Barbara mentioned some of the really extreme cuts to HUD that is in there. So right now, we are in a congressional recess. Congress is back home, and they're coming back on Monday. And they have a lot coming up. They come back on Monday. Trump, not pictured here, is on Wednesday of next week, is Trump's 100th day. So that comes with some of his own personal deadlines. And at the end of the week, Congress needs to reach an agreement and pass a spending bill for fiscal year 17. I'm trying to hash it out here in a way that makes sense. There's a lot going on with budget, a lot of big words and appropriations and reconciliation, resolution. So next week is for fiscal year 17. That's the deadline. That is unrelated to the budget cuts Trump released for HUD. What happened was last year, rather than putting together a comprehensive spending bill, Congress said, you know what, let's just do a temporary measure that gets us to April, and then we'll figure out the budget then. And so that's where we are now. They have to figure it out. If they can't come to an agreement by the end of next week, there's a chance to face a government shutdown. And for this budget, Congress has already put together spending bills. They've already been working on it. As I said, they've had since last year. Trump did come into office and said, hey guys, this year I want some more billions of dollars for a wall. Didn't go over too well as this budget's already in play. And another key point of the budget when we look at these deadlines is, thankfully, there is a pretty good system of checks and balances set up for the budget process. The House puts these budget bills together, and it has to be passed with 60 votes in the Senate. That means they need Democrats to get on board. So for this to get through Congress, we need some form of bipartisan support. And then what's in budget is done and out of Congress, it still needs to be signed by the president. So that poses some problems for getting things through, but it also can let some of us rest a little easy knowing that there is that system of checks. We do need some form of bipartisan agreement. So that's just next week. And after they figure this out, Trump will release more budget recommendations. This will include more on taxes. He'll go into details, mandatory spending, economic projections. He's going to release a lot more, and Congress will get to work figuring out that budget before their deadline for the beginning of fiscal year 18 at the very beginning of October. And Barbara already talked about the Health Center primary care funding cliff. That happens on September 30th. A key point here is that that funding cliff is separate from the budget and appropriations process. There will need to be its own piece of legislation to get funding for that. Although related, it's not tied in to the budget process. And So what's on all of our mind is, well, where does healthcare fit into this? What's going on? The HCA failed, and the answer really is we don't know. There's a big to-do list here. You can see on my cute little graphic here, Donald Trump, Senate Leader McConnell, and House Leader Ryan, they have a lot on their minds, a lot they want to get done. They have tax overhaul, the border wall. I mean, again, this list goes on, and we could talk about that forever. So we don't know if healthcare were going to come up. A Politico news alert just went out today that they want to still try to get something done with healthcare before the fiscal year 17 budget deadline, which, as you see, is at the end of next week. What we're hearing on that and reading on that, I should say, is that it won't include Medicaid. But again, we don't know. We don't expect anything big to get through, as it already failed and we have so much to do, but we're prepared for anything. So what have we been doing at the council? Since this year and since the new Congress and Donald Trump got in office, we've really been focusing on keeping the progress made under the ACA and emphasizing the need to continue to expand Medicaid and to not take away what we already have. And again, as we went over all these budget problems and the cuts to HUD, focusing on that, focusing on the appropriations process and keeping these programs alive and supported and funded, and then of course focusing on single payer. The method of what we're doing and how we're doing this is through, and this is a huge one, Medicaid stories is a really big part of this. I'm probably going to say this again before this is over, but I am hearing everywhere from our partners up on the Hill, from congressional staffers, from Congress people themselves, that Medicaid stories are one of the most effective way to get that message through on what these changes to healthcare really mean, putting a face to Medicaid. So that's what we've been trying to do, and collecting stories. We have a Medicaid story site that will be on a resource sheet where you can submit them. So we're taking these and we're incorporating them in our advocacy work. We're putting them in letters. We're sending them to congressional offices. We're trying to build the human side of all of these policy changes. And we'll talk a little bit about the Mobilizer in the next few slides. We've been featuring Medicaid stories on the Mobilizer each month if you want to take a look and see an example there. So we're going forward with these Medicaid stories, engaging with Congress, and engaging with Congress in a few ways, whether it's sending stories, encouraging you all on the phone to call in, and meeting with them myself within coalition groups. We're sending letters. We sent letters to congressional offices on the dangers of the American Health Care Act, on the dangers of block grants and per capita caps, and again, working with our coalition groups all in teams to do this and sign on letters and really get that message out on the Hill as best we can. A great way to keep track of this and to learn how you can be involved is the Mobilizer. Each month we put out what we've been working on, what we've been hearing, what we've been learning, and putting it into the Mobilizer. So enough about me. What can you do? We have a list here. It's not comprehensive, but it's a great short list of action items, from scheduling a site visit at your HCH project to tweeting your lawmaker. And I'm going to go through some of the logistics of doing these. I'm going to go fast. There will, of course, be time for questions. And as a special treat to everyone on the webinar now, we have 2 action items for you to do right now. You can go home today and say, I did something. Hannah is going to share a sign-up link for the Mobilizer. You can go and sign up for this. You'll get an action alert every month. You'll stay up to speed. So sign up here on this link. And here is the Capitol Switchboard letter, the second one in red. Something I would love everyone to do right now. It takes 20 seconds. We all have smartphones. Is put this in your phone. Now, I can't take credit for this strategy. I learned this from Barbara, but it's a good one. If you save it on your phone under Congress and you have Siri, you can drive home and say, hey Siri, call Congress, tell them your representative or senator's name, and get right to their office. It's a really fun, speedy way to get this done. So everyone wants to save this number in their phone right now. That will make me feel great, you can feel great, and we can move forward and talk about advocacy from there. And we will put this number up again, but it's been up for a bit, so hopefully everyone's seen that 202-224-3121. All right, so top of the list is scheduling a site visit. As I mentioned, putting a face, putting a picture of what health centers are, of who Medicaid is serving, is one of the most effective ways to reach Congress. Scheduling, I put up on top here the recess dates. You can call Congress with that number that you've already saved on your phone, ask for your office, ask when your representative or senator will be back in town. They might be in town outside of these dates, so it's worth calling. It's, as I said, a great way to really show them what's going on. Sometimes I hear from folks, well, I don't have a big conference room, I don't have the resources, and I really want to emphasize that they work for you. It's not the other way around. If you don't have enough resources to have the big site that you want, come show them that. If you've been able to expand your services through Medicaid, show your representative and senator this. They work for you, and they need to see what's happening on the ground. It's really easy. You can call in, ask to speak to a scheduler. We have template letters for you to send an invite. It's absolutely not required. You can really just call and email back with the scheduler. It's pretty easy to do. And once they're there visiting you, we have all the materials you need and talking points. And of course, don't forget to tweet us a photo. Another action item is writing a letter. Barbara spoke a lot about things going on at the state level. If you can write a letter to your governor, that's fantastic. We have a letter template for that. Write to your congressperson, we have a template for that. And when I say write a letter, you don't need to mail in a big fancy printed letter. This can be a couple of sentences with your name typed out in an email. It can be as simple as this. You can take one of our letter templates, save it as a PDF, and shoot it in an email. In fact, I think a lot of congressional offices will prefer it this way. Another way to bring attention is writing a letter to your local newspaper. Try to get what we care about. Try to get these headlines out there. We have, again, templates for this. This will all be on the resource page, so this is a great way to bring attention. The next action item is meeting with your congressperson. There's a couple places you can do this. You can do this in D.C. If you're going to be here for the national conference, please let me know. Please visit our Hill Visit page on resources. Let's get you in a meeting. Barbara put in a plug for our health policy PCI on Wednesday. Come in Wednesday, shoot me an email. We'll get you in for a Hill Visit that day or the next day or Friday. You can also visit your member anytime they're in their home offices. All members of Congress have an office in district. I bet you that of all of you on the phone, there is probably a congressional office that's open right now within 3 miles of wherever you're sitting. You have the Congress number saved in your phone. Call that number. Ask them for information on their local office. That congressional switchboard will get you to their D.C. office. So you can always call the D.C. office and get information on the local office. It's all online. And here are the recess dates again. That's a great time to try to schedule a visit. And you can always call and see if they'll be in town another time. Another way is to join me on Capitol Hill. I can serve as a proxy. You can join me. This is really easy to do. I can schedule a visit, go in, do my national pitch, and just call you in for 5 to 10 minutes to talk a little bit about your project. This is something I love doing. It gives me more leverage and attention when I'm there. It allows my message to be more effective, and it will allow you to literally have your voice on Capitol Hill here. Shoot me a note, and we'll set this up. And happy to help facilitate any type of meeting, even not in D.C. I'm happy to help you contact your local office, anything you need. So Medicaid stories, which we're really pushing. We have our Medicaid site, Medicaid website where you can put in your Medicaid story. Here's a story here. What the message that we are trying to collect is what has Medicaid done for you to help you, or what has not having it, what would having it mean if you don't have it? The story here, there is a sentence near the bottom bolded. Really, this is all we need, a couple sentences. I don't need a whole typed out few paragraphs. A little note on what this meant really goes a long way, and at the end of the day, it's these bolded sentences is all we can really have, all we can really convince our congressmen to read. So send these stories in. We have the Medicaid story sharing site. So another thing you can do is just be active in the community and go out and attend things. Barbara and I are attending a town hall here today. It's across the street from our office here in Baltimore. There's townhallproject.com. If you're feeling brave, you can ask a question about healthcare, ask what they're going to do to protect affordable housing and Medicaid. I'm not going to tell you to be passive, but you could probably be passive and sit there and someone else will end up asking as it's a hot topic. You can go, you can clap, you can be there. All of this makes a difference. And of course, we've all seen the marches. There's March for Science coming up. You can find more information on marchforscience.com. And a great sign is Science is Housing is Healthcare. And take a picture and send us a tweet if you go, please. So another action item, we've pressed this a lot, calling and tweeting. All of you on the call already have Congress Switchboard saved in your phone. Ask for your senator or representative. You can say something as simple as, "Hi, I'm Regina. I'm from Baltimore. Thank you for not voting yes on the HCH. I appreciated it." It can be as simple as that. We have a script here for you. And of course, that same message can be in a tweet. We have an example tweet here of us doing it from the council's account. Any way you can connect means something. I have been in offices waiting for meetings, sitting in the lobby, and I have seen the person at the front desk pick up the phone and do a little tally mark on a sheet of paper, and that tally mark makes a difference. They're paying attention. Low pressure, give a call or a tweet. All right, so that is our action items, and I would love to know what you all are interested in. I know that, Hannah, we have a poll to come up. This is not a commitment. What are you interested in after hearing this? If you're on right now, if you could please turn to the screen and check all that apply. And if you haven't done your 2 action items from today of signing up for the mobilizer and adding Congress to your phone, do that now. I know it's covered right now, but the Congress number is 202-224-3121, and that's the Congressional Switchboard, so you can get to any office. You call them there and ask for them. All right, very cool. So we have a lot of people interested in attending a town hall probably this week. I can't wait to hear about it. Attending a march, and almost 40% going to write a letter. Sounds great, guys. All right. I will put this away. Okay, so now I believe we are opening it up for questions.
Okay, so we've gotten a number of questions while we've been talking, and so I want to come back to some of those. One of the questions that we've gotten is following up on Regina's offer to be a proxy in D.C. And so can you describe a little bit more about what that would look like or how people do that?
Sure. So I've done this before, and I'll set up a meeting in D.C. I can try to get in with the actual senator or representative. We'll probably, most likely for scheduling purposes, be with the legislative staffer who works on health and housing issues. So I set that meeting up. Meetings on the Hill are very short, usually last max 30 minutes. I will have you send me when you're available. I will reach out to the staffer, set up a meeting with them. Beforehand, we can talk over email or over phone just to prep logistics. And then when I'm there in the meeting, I'll go over some of our national priorities and then call you in via my cell phone, or sometimes they allow us to use their conference line, and just have a conversation. Talk about whatever's important to you, what you want to talk about. A lot of the times when I'm in these meetings, they have questions, and these aren't hard questions. Nothing to be scared about. What does homelessness look like in my district is a big one. What type of services you provide, or if you're not running a clinic, if you're a provider, tell me about your experience as a provider. It's pretty easy, and again, these meetings are short. If they have a question, they'll usually have 1 or 2, and I'll be there trying to get them more interested and drag it out. But really, we just pick a date, and you'll conference in for about 5 to 10 minutes, and it really makes a difference. So that's how it goes. And shoot me an email if you have any further questions on logistics, and we can work something out.
I think one thing I'd add to that too is in talking with policymakers, people don't generally understand or have not thought about the connection between health and homelessness. And so even just having providers, consumers, your administrators, your CEO, anyone in our community is a good representative to talk about, hey, here's how homelessness and health intersect. The challenges of living on the street and being sick or having health conditions and trying to manage those responsibly. I think when you're talking with particularly a conservative perspective, people don't think through what that personal responsibility discussion, like you can only take that so far before the guy living in the park can't keep his medication safe. And I think most people will understand that, but just have never had anyone really kind of talk them through it. And most people have said, oh, I never really thought about it that way. And it's from that point that you can build a larger conversation. So excited about that and doing a proxy in D.C.
Yep, and I want to add a note, too, that this is something I want to do. This is the opposite of a burden on me. It makes me appear more valuable if I can bring a constituent in. So
let's help justify Regina's job.
Justify my job. Please participate.
Okay, so a couple of other questions we've gotten roll in. So one says, tell me more about Medicaid waivers. And I had glossed over this. Medicaid waivers are, again, the kind of thing that can bore someone to tears within 30 seconds. I'll try to make it sound exciting. A Medicaid waiver is essentially asking permission to waive a typical Medicaid requirement. And so that's really all it is. And every state has tons of different ways that it waives Medicaid requirements. A lot of us are probably most familiar with home and community-based services, like for seniors or people with disabilities, to allow my grandmother to stay in her home instead of going to a nursing home and get in-home services. Those are typically delivered through a Medicaid waiver so that those services are funded through Medicaid. The way that Medicaid waivers have been extended, particularly to better serve people who are homeless, is to think about how can we more flexibly use and fund, using Medicaid money, housing support services. Can we pay for a care coordinator? Can we pay for an outreach worker? Can we pay for a case manager? Can we pay for someone who helps stabilize someone in their housing? Can we pay for the types of medical respite services that we know are really critical for people with healthcare needs coming out of hospitals? Really thinking flexibly and innovatively about how we can use Medicaid and flex those options that we have at the state level is really a good way of being able to design a really innovative program. Was it 2 years ago now, the Obama administration had issued an informational bulletin, essentially a memo to state Medicaid directors saying, hey, here's a very specific list of housing support services that we think Medicaid could pay for. So if you want to ask us for permission to do this, we're ready to say yes. Now Medicaid waivers can include that, but they can also include other things that I had mentioned before, like permissions to do the work requirements and do all of those other things. Again, it's thinking about how we're using our Medicaid program most flexibly, and the waiver is the mechanism by which you would do that. Now, it's important to remember that every state is required to have a Medicaid advisory committee. So if you don't know who is on your Medicaid advisory committee in your state, Google the Medicaid advisory committee in your state and find out when that group meets, who's on it in your community. It might be that you'd be in a really great position to get nominated to those types of groups. Those are really good forums for having their ear to the ground and knowing what's going to change in your Medicaid program. And any change to your Medicaid program through a waiver does require a public comment period. So you have an opportunity to weigh in and say what a terrible idea you think work requirements are, or what a terrible idea you think that charging $50 premium or a $50 emergency room copay to someone living in poverty might be. So that's your opportunity to do that. If you hear emergency vehicles in the background, it's because this is an emergency. So, I mean, I'm glad to hear that people are responding to this, because that is how we should be treating this. This is pretty urgent. And significant changes that are happening or being proposed now can really roll us back from a lot of the gains that we had made. So that's on Medicaid waiver. Did you want to add anything?
And I want to say we have compiled a bunch of resources on this information sheets. That is in the pod where it should be on your lower right. It's called resources. All the links we've been referencing are there, including more on Medicaid waivers.
Yes, thank you. Okay, so I've had another question come in. Someone has said, and I totally understand this, it's really frustrating talking with my member of Congress because he doesn't agree with anything I have to say. What do I do and how do I remain active? So I think this is a really great question. For those who are skilled in motivational interviewing, this is a way of communicating with clients in a clinical setting to establish common goals and a common understanding of where you want to go, keeping things open-ended. I think we are really skilled in the healthcare for the homeless community to have conversations that are goal-focused. And so I think one of the things that's hardest is for us to set aside how crazy it makes us and think about how can we take the long view here because we want the client to come back. That's where our clinical model is. And so we want to build a relationship with the people who represent us. Regina is absolutely right in that they work for us, but at the same time, how do you really develop that so that you become a trusted resource? And many times, members of Congress will call the healthcare for the homeless if they've got questions, and it may not be that we always agree. We know in a clinical setting we don't always agree with where goals are set or what actions are happening, but yet we remain engaged. And I think that's where we need to be. And maybe this is my polite way of saying treat your member of Congress like your patient. In that, you really want, I think we can establish that no one wants to be homeless. We can establish that homelessness is not good for the community. We can establish that no one wants to see emergency room bills and our hospitals being used in a way that's not efficient for anyone. We can all agree that there's a better way to use the limited resources we have or how we can reallocate resources to be more responsive to community need. And so coming at it from open-ended questions in a way that positions you as an expert, but not in a philosophical or position-based way, but in a way that opens a conversation. A great way to practice is with your friends and family, especially if you have someone in your family that you don't agree with at all. Practice these open-ended questions. It really can yield a conversation that actually can open up new opportunities to really understand one another in a way that hadn't been possible before. And I think that is one of the hardest asks that we can make, is that's hard. And Regina, you're the one who's on the Hill too. Anything to add there?
Yeah, and what Barbara said, there's always a place to start. And I've been in meetings with Freedom Caucus members, and even in cases like that, they might bring up that they support the health center system, which is a great jumping off point to talk about how Medicaid is working within your health center. And it's never hopeless. There's always a chance to move the needle, and we're never going to move the needle if we don't try. And even if you don't do a face-to-face meeting, there's all these little steps and action items to work on that needle that we've outlined here. So please don't give up or not act.
Oh, also, yes, also consistent with the model that we use to engage the people we serve.
Harm reduction.
Harm reduction. So think about that. Okay, so here's another question that's come in. I have called my congressman, but I just don't really feel like it makes a difference. Can you tell me a little bit more about how these calls work? And so, Regina, I know you touched briefly on how the staffers respond to calls, what happens there, what those calls mean.
Sure, and this is something that I've asked staffers because I say, listen, I'm begging all of our members to call in. What can I tell them to let them know it means something, especially when I have people coming and saying, well, my representative is already very supportive, or my representative is so far away from me they would never be supportive. What they've told me is that when phone lines are flooded, every single staff person in the office knows, and that message does get to their boss. It does get to the senator or the congressman. And as I said, I've seen them checking off call numbers to report back to their boss. So, and we've seen votes here where some senators have changed their votes and they've cited it to these calls that are coming in. So it does work, and again, it's harm reduction. Even if you're just a tally mark of 400 tally marks that won't end up changing how your representative votes, somewhere in the back of his or her mind is that the constituents care. So I say keep calling, and again, it's so easy. It takes 10 seconds. You're not taking up too much of your time so that it's not worth it. That 10 seconds is totally worth that check mark.
I would also argue that it makes you feel better.
Mm-hmm.
And so altruism aside, do it for you because
Right.
you will feel better if you are able to participate. And I think that's what we try to do in client engagement. We try to do that in our own civic engagement, is that a democracy works when we're all engaged. And so I know that sounds trite to say, but continuing to call might just be for your mental health as well. Okay, so next question we've gotten here. What is your best guess or your prediction regarding the September funding the health primary care cliff and its resolution or not? Regina, what's your thought?
So I'm shaking the magic 8 ball right now. Give me a second to see what comes up. Well, no, just kidding. Right now we're remaining hopeful. There's a team of people, and we're not alone in the advocacy for this. And we've seen the funding come through before. It came through in a big bill called MACRA about 2 years ago. We're hopeful that it can come through again. As I mentioned, it will need to be through its own legislative vessel. And nothing is confirmed out yet, but again, we haven't confirmed that nothing's not coming out. We're hoping to see that, and hopefully we'll have some good news to share about that vessel coming out soon. So I feel hopeful. I feel empowered with a big community of health center supporters around us. And health centers have always been a bipartisan issue, which is something to remind yourself when you shoot up in the middle of the night anxious. And it's a bipartisan issue. We expect and hope for bipartisan support. So I think it will happen, but it will certainly require advocacy on our part, especially with so much else going on, that this can get pushed under the rug to worry about later. We can't worry about it later, so we need to be loud about it, but I think it will be okay, and it's nothing to lose sleep over just yet.
Got it. Another question we've had is about state-level advocacy and how to engage Medicaid directors. So wanted just to revisit that because, again, I glossed over a lot. Having a relationship with your state Medicaid director is really valuable. They often can be much more accessible than your governor, but your legislators also on key health committees in your state legislature can also be helpful. Your local public health commissioner or your local public health officer, your behavioral health folks that run that for your town or for your city, all of those local folks as well as your state Medicaid director can be real advocates for you as well. And so if you, I know Regina talked about site visits and having your congressional representatives come to your clinic or to your project, but having a wider range of staff also come and visit you can really help build your support so that people will come to you, again, in your state and your local community as experts on this, but they also can engage you in the solutions that they're looking for as well. Everyone's trying to turn the curve on chronic health care conditions, battle the opioid epidemic, childhood obesity. I mean, just like these are the kinds of things that we know all communities are trying to wrap their head around in the general population. So having us at the table at a wide range of forum is really helpful because we can spread our expertise that way in both small and large. And again, your Medicaid director might be more available to you to come and visit your project, do regular meetings with them. And maybe this is happening at your CEO level, like not everyone's in a position to be meeting directly with the Medicaid director. But if this is something that really interests you at your project, find out what the relationship is. See if there isn't something that can happen there. Health fairs and all of those kinds of things that health centers do regularly can be really great venues for both elected officials, but also those political appointees that are so key. I know we're coming up on time, and so really we can't get to the rest of the questions. Would love to continue this conversation. Want to let you know that after this closes out, there will be a survey pop up. Please fill it in. We'd love to know how we can best design trainings for you. We'd like to know what other topics you'd like to learn more about. So if you can help us at the council provide more resources for you, that would be really great. Again, just want to offer the contact information for Regina and myself. Please reach out to us, tweet us. Let us know what you're doing in the field. We really want to have an active and engaged community, and we're hoping that this is just one forum to do that. So thank you again. Really appreciate your time today, and hopefully these resources can be helpful for you. And with that, we will close out the session.
Thank you, everybody.